Buenos. Sorry, I'm not speaking Spanish, so I will try to speak English, French English. Okay, and first of all, I would like to thank the scientific committee for their invitation, and in particular, I would like to thank my dear friend Adrian Gadano, who spent, I don't remember, but 5 years with us in Paris, and it was a huge pleasure to have him with us. Okay, so pathophysiology of infection in patients with cirrhosis. I must say that we have some new concepts, and these new concepts have been introduced by immunologists, and I would like to share with you some of these ideas. First, bacteria express unique structure, molecular structure, which are called PAMPs, pathogen-associated molecular patterns, and these molecules are detected by receptors which are expressed in the innate immune system. These receptors are called PRRs, pattern recognition receptors. In this slide, I give only few examples of PAMPs and receptors, including two families of receptors, toll-like receptors referred to as TLRs, and node-like receptors. This for the example. And you can see that gram-negative bacteria or mycoplasma express triacyl lipopeptide, which are recognized by dimers of TLR2 and TLR1. Gram-positive bacteria express diacyl lipopeptide, which are recognized by dimers of TLR2, TLR6. Gram-negative bacteria also express lipopolysaccharide, referred to as LPS, which is recognized by TLR4, etc. And also, almost every bacteria express peptidoglycan, which are recognized by node 1 or node 2 when the PAMP is within the cell. This is very important to understand. The process of recognition of PAMPs by innate receptors is called structural feature recognition, okay? But as you can see in this very simple cartoon, bacteria are also able to express other molecules than PAMPs, I mean virulence factors. And these virulence factors are not recognized directly by the innate immune system, but indirectly through functional change this virulence factor induce. This is very important to understand. For example, there are bacterial exotoxins which behave as a channel in the membrane of the host, and when the channel is in the membrane, there is a potassium efflux which is sensed by the inflammasome. And you know that the inflammasome is a very important system for the defense against bacteria. And in this cartoon you can see that both structural feature recognition and functional feature recognition converge in the induction of several pro-inflammatory or inflammatory molecules, including TNF-alpha, IL-6, IL-8, a lot of prostanoids, interleukin-1 beta, etc. And the primary objective of this inflammatory response is to reduce bacterial burden. It is very useful for the host. But in some individuals, this inflammatory response is excessive. There is a cytokine storm, and this cytokine storm can cause tissue damage. And this process is called immunopathology. And also, please note on the right side of the cartoon that virulence factors can cause tissue damage directly. And tissue damage, for example, necrosis, is able to release molecules which are called DAMPs, for danger-associated molecular patterns, which are able to induce or perpetuate, accentuate inflammation in the context of sepsis. This is very important because we should have this potential role of DAMPs in the inflammatory response to infection. Okay, so we all know, and the previous speaker explained this very well, that patients with cirrhosis are susceptible to develop bacterial infection. The question is why? The first reason is the existence of an impairment of epithelial barriers. And the paradigm for this is the gut. This cartoon summarizes our knowledge about bacterial translocation in the context of cirrhosis. And as you can see, it's a very complex alteration. The first one is that patients with cirrhosis develop a dysbiosis because of diet, because of antibiotics, because of decreased bile flow, because of decreased intestinal mobility, decreased gastric pH, and probably also a decreased impairment in the gut immunity. And this results in the dysbiosis. This is the first phenomenon. The second phenomenon is located in the mucosa, and as you can see, that monocyte macrophages are able to produce cytokines locally, or nitric oxide, and these cytokines make a lesion, I would say, a disruption of tight junction in the intestinal epithelium. And the result of all this alteration is that bacteria can translocate from the lumen to the blood and cause infection. Also, please note that bacteria can produce microbial metabolites or even PAMPs. We saw PAMPs previously, and these PAMPs or metabolites can induce per se inflammation. Okay, so we have here a mechanism for, I would say, an increase in permeability of the intestine, leading to a translocation of viable bacteria causing infection. And the prototype is SBP. There is also another mechanism, which is a defect in neutrophils. You know, neutrophils are the first line infantry against bacterial infection because neutrophils produce a very powerful molecule which kills bacteria, and this molecule is called superoxide. We and others have shown that neutrophils from patients with decompensated cirrhosis, when stimulated by a bacterial product such as FMLP, have a defect in the production of superoxide anion. And this probably is a very important mechanism for the decrease in bacterial killing in this patient. And this mechanism is acquired because when you use, for example, an agonist of TLR4 or 8 receptors, this agonist is called CLO97, you restore the ability of neutrophils to produce superoxide and to kill bacteria. Another possible mechanism for the risk of infection in cirrhosis is related to genetics. There are single nucleotide polymorphism which have been associated with the risk of SBP. Here I show the results of some of these studies. You have the first author on the left, the gene symbol, which is the targeted by the SNP. The SNP ID, which is always RS and some numbers, and the outcome. And as you can see, there are 3 studies showing that SNPs within node 2, TLR2, or FXR, which are associated with the risk of SBP. But I would say that these studies are interesting, but there are millions of SNPs. Therefore, they could have missed very important SNP. In other words, they selected too few SNPs in these studies, and now we have to perform large genome-wide association studies looking at the genetic risk of bacterial infection in patients with cirrhosis. It is a very important point, because if you identify SNPs which are associated with the risk of infection, you can build prophylaxis using, for example, antibiotics with confidence. Of course, we know that infections are very severe in patients with bacterial infection, of course, and the first mechanism is an increase in circulating cytokines. There is a cytokine storm in these patients. And here I summarize our results in the canonic study regarding patients who are admitted for infection-related acute decompensation of cirrhosis. And as you can see, 70% of these patients have traditional acute decompensation because they have low-grade systemic inflammation, I mean low circulating cytokine. They do not have organ failure, and they have a very low in-hospital mortality. But there are 30% of the patients who have ACLF, acute on chronic liver failure, because they have high-grade systemic inflammation indicated by a cytokine storm, organ failures, and high in-hospital mortality. Yes, but do we have an explanation for the cytokine storm in these patients with ACLF? I would like to remind you results already described by the previous speaker, but this is a reanalysis of the canonic results by Javier Fernandez with the angle of infection. So he looked at infection in traditional AD and in patients with ACLF. And as you can see, in patients with ACLF who were infected, lungs were the commonest site of infection, and of course, the most common mode of acquisition of the infection was nosocomial. 80% of patients with ACLF, in fact, had nosocomial infection. And a large part of these infections were caused by MDR, multi-drug resistant bacteria. And I think that it is a very important result. Of course, you can say people who develop ACLF have a more severe underlying liver disease. But remember, bacteria can produce virulence factors which can cause tissue damage, and tissue damage can accentuate or perpetuate inflammation caused by the bacteria. And I think that we should look at this. In other words, MDR can cause direct tissue damage in these patients, and we have to investigate this hypothesis. Another point is that, again, using canonic results, here by John Claria, we showed that the profile of systemic inflammation was different according to the trigger. Here, you have 3 groups of patients. All these patients have ACLF, but some do not have any trigger, some have bacterial infection and no active alcoholism, and some had active alcoholism and no infection. And as you can see, during sepsis, the profile is driven by IL-6. In contrast with alcohol, the profile is driven by IL-8, interleukin 8. Therefore, it is very important now to understand which mechanisms are driving, the profile of the cytokine storm, either IL-6 or IL-8. And we have to probably to make new studies with this objective of understanding these alterations. And of course, genetic factors could be involved in the severity of systemic inflammation. We have many examples outside the liver of disease which are driven by systemic inflammation, and systemic inflammation itself is driven by genetic factors. In the case of ACLF, we don't know. We do not know, and therefore we have to perform GWAS. And this is one of the objectives of the next study called ACLARA in South America. I would like to show you some new results obtained in my lab regarding neutrophils. We love neutrophils, and I will try to explain why. Here we did a pilot study. Hopefully it will be published very soon. 7 patients with stable decompensated cirrhosis, 7 with traditional AD, 17 with sepsis-related ACLF, and 7 healthy subjects. We took blood within 6 hours after admission to the hospital. We looked at white cell count and differential counts, and we performed high-throughput transcriptomics in whole blood in order to identify differentially expressed genes referred to as DGs. The first result is very simple but very interesting. We confirm that in patients with ACLF you have leukocytosis, increased number of leukocytes. This is a confirmation of the canonic results. But look at the left, you can see that these patients have neutrophilia associated with lymphopenia and no change in the monocyte count. Therefore, ACLF is characterized by leukocytosis and neutrophilia. And this is the profile, a feature of what the hematologists say, emergency hematopoiesis. Therefore, ACLF is characterized by emergency hematopoiesis. And now we compared, you remember we had 4 groups of individuals. We compared stable cirrhosis with AC subject, traditional AD with stable cirrhosis, and ACLF versus traditional AD. This is a volcano plot. In the volcano plot, the red color indicates upregulated genes, the black color indicates genes which are non-differentially expressed between the 2 groups, and green color indicate downregulated genes. Since you concentrate on the right part of the figure, ACLF versus traditional AD, you can see that the most upregulated genes in the blood of these patients with ACLF are CD177, arginase 1, and MMP8. And all these genes are selectively expressed in neutrophils. And CD177 is a marker for activated neutrophils. And this is a very interesting molecule. We confirm using flux cytometry that the protein also is overexpressed. The percentage of neutrophil expressing CD177 circulating in blood of patients with ACLF is increased. And this is a very important result because we know that CD177 is a surface marker which allows adhesion of activated neutrophil to the endothelium in vital organs. Therefore, we are now looking at the role of this neutrophil in the induction of organ failure. And the working scenario is the following one. It's very, very simple. So the master of the game is the overexpression of cytokines, okay? In blood, but maybe in the bone marrow, because there could be a local regulation of hematopoiesis by GM-CSF, interleukin-1 beta, interferon. And these cytokines cause emergency hematopoiesis with prominent CD177 expressing neutrophils. And this CD177 expressing neutrophil go into the organs at the level of the endothelium and can cause tissue damage. But also please note that there is, of course, other mechanisms for organ failure and caused by cytokines, which, for example, can activate endothelium, can stimulate the tissue infiltration by other immune cells. But in my view, the neutrophils are playing a central role in all these alterations. So, in conclusion, patients with cirrhosis are susceptible to bacterial infection because they have increased bacterial translocation and acquired defective bacterial killing by neutrophils. Genetic variation may also contribute to the risk of infection. Sepsis-related ACLF is characterized by increased circulating cytokine levels. The role of microbial factors and/or host genetic factors in these increased levels deserve investigation. Increased circulating cytokine levels may induce organ failures through effects on vital organs, for example, endothelium activation, and also by stimulating emergency hematopoiesis with the prominence of CD177 expressing neutrophils. I thank you for your attention.